JAK2 inhibitors.
No, somebody with myelofibrosis getting a transplant, will it be like, I don't know really.
No, really, because if you look at the biology of this chronic GVH, is so much different from acute GVH. Chronic GVH is an autoimmune disease. When the stem cell you're given, because it's not autoimmune disease when you do acute GVH, the T cells that you're given, but they're gone. But the one 6 months down the line is that the new stem cells, new T cells. So I suppose that given THOT, if you think logically, probably prophylactically, it may not work much. So you might like to work at that point of time, you might have other biomarkers, whether you can predict chronic GVHD going to happen or not. Chronic on acute is all right that you know, that's a good condition to do some experiment, clinical trials, but in all others, I suppose we have to have biomarkers and then bring in these kind of drugs to tackle chronic GVHD.
Just to share an experience, we had 4 or 5 transplants in myelofibrosis. One was really having a blast count of somewhere between 10 to 15 or something like that. So in that we, more than using ruxolitinib, we use azacitidine for 4 to 6 cycles, get her into kind of a decent remission, and then we went on with more like an AML to MDS kind of a stuff. We don't have any, just data is coming up. The use of azacitidine with ruxolitinib and stuff like that.
It's a reasonable approach. It's quite a reasonable approach. So, this none. Thank you so much.
Thank you. We'll go to the next talk. We have Dr. Menon, who is senior consultant at Sidecare Cancer Hospital, Bangalore. He's got his special interest.
Organizers. Without much ado, I'll just get down to the topic. Though we all know that perhaps the #1 indication for transplant today is acute myeloid leukemia, we still are grappling many a time to understand where we need to really intervene and where we need to step back a little bit before embarking on a potentially difficult treatment for myeloid leukemia. Now, having said that, unlike what it was about 30 years ago, transplant has become a lot more acceptable for patients, especially because of the significant improvement in the supportive care, the medications that are available, and also the expansion of the donor pool, wherein with the availability of haploidentical transplant, we can, if we choose, almost have 90% donor availability for if there is an indication for transplant. So we know that myeloid leukemia is a heterogeneous group of disorders with a differential outcome to a common treatment. The induction therapies have not changed very much in the last 40 odd years, 30 odd years, but we do understand the biology of the disease, starting with the seminal paper in 1998 from Grimway, where you had the cytogenetic classification into the good risk, the intermediate, and the poor risk group, and then subsequently understanding that the normal cytogenetics is not exactly normal cytogenetics with extensive genomic aberrations. In fact, the most diverse entity, which is the intermediate risk group. And as I said, the availability of reduced intensity conditioning, and also the expansion of the alternative donor stem cells, we have had to relook more carefully as to whom we can actually transplant in AML. But of course, the challenge is always to ensure an optimum outcome, because we know that on one hand, when you're doing a transplant, you're going to end up with inviting a lot of trouble, as Dr. Saike just said, as an autoimmune disorder in the form of a graft versus host disease, while you may eradicate the disease. So it is basically a balancing appropriateness, benefits versus toxicity of a particular therapy. We know that one of the fundamental problems in myeloid leukemia is that it is a disease of the older age group, and that's also one of the banes, because when you want to treat a patient with a transplant in older age group, it is always going to be a challenge. And we also know, in my subsequent slides, I'll say that the outcomes of a transplant in an adult patient above the age of 40 is certainly a little inferior to patients below the age of 40. And we also encounter a significant number of adverse cytogenetic profile in patients in the older age group, which makes it all the more difficult. We also know from several registries, I've just chosen one of the registries, the Swedish registry, which tells us the outcomes as we go with increasing age, it becomes worse. And we know now that with more diversification and understanding of the cytogenetic risk groups, we have the displaying of curves, understanding that there are certain specific cytogenetic risk groups which will do better than the other. And besides, of course, the baseline ones, which is for the inversion 16 and the 821 and the intermediate risk group, where you are traditionally saying there are no karyotypic abnormalities, versus the deletions and the monosomies and the monosomal karyotypes, which have come into the understanding of AML cytogenetics in the past decade. We know that there are differential outcomes based on the cytogenetic profile. As against the tumors of the solid solid counterparts, it is quite unusual that the leukemics do not have too much of genetic abnormalities as compared to the solid tumors. But certainly those genetic abnormalities partner with several other genetic abnormality to contribute their impact in terms of the outcomes for patient. So largely, if you look at these different molecular abnormalities, it is the FLT3 mutations, it's the NPM1 mutation, the SEBBPA mutations, the co-binding factor leukemias, the ASXL1 mutations associated with spliceosomes, broadly into these categories. But what we also understand that these are not quite mutually exclusive. The balanced translocations do not mix up with some of the NPM1 mutations, and the NPM1 mutations are mutually exclusive from a TP53 mutations, the chromatin spliceosome, the IDH1, all have their distinctive features and very rarely intermingle with one another. But at the same time, you may have partnering interactions with different mutations, as we will see in the Sarkos plot. And this is just to show the diverse nature of the mutations that are present for one particular abnormality that is detected in terms of mutations at the molecular level. And because of these, we have been able to sort of stage migrate some of the intermediate risk group back into a favorable risk group patients, and that is to the tune of about 7 to 8% from the intermediate risk group to the favorable risk group, and also about 10 to 13% from the intermediate risk group to a poor risk group based on these molecular profiling. And to make things easier, the ELN group have given some recommendation for us to sift through all this confusion to give us some framework within which we can actually act upon in terms of determining how best to treat an acute myeloid leukemia. So should all patients of acute myeloid leukemia be transplanted in first remission? That's always been a question that has been looked into. We have, from the mid-90s, a series of prospective clinical studies to answer this question. And many of the randomized trials in BMT have not been actually randomized, but what we call a genetic randomization, depending upon the availability or non-availability of a donor. To address this issue, there was a paper in 2000 which said that all patients, which suggested that all patients of acute myeloid leukemia will benefit with an allogeneic stem cell transplant. But that was sort of mellowed down, that statement was sort of mellowed down 7 years later from this more well-conducted study from the Hovon-Sack group, which actually looked at a donor versus no donor analysis of myeloablative transplant in first remission for acute myeloid leukemia, and they did not consider patients above the age of 60 in this study. Now, for sure, this was a well-conducted study, and it included more than 5,000 odd patients in the study. And they had, and when you looked at the analysis, there was definitely an improvement for those patients who underwent a transplant in CR1, not so much so for patients who had a favorable cytogenetic risk group, but certainly impact in patients who were having the intermediate risk group and the favorable risk group. At the same time, there were other studies which were published in 2003 and 2001, both from the ERTC group and also from the Golem group, which suggested that the ERTC said that only the poor risk group will benefit from an allogenic stem cell transplant and not so much the intermediate risk group. But those were early stages when the molecular profiling was not so robust. But what the Hovansak group did was they did a meta-analysis including the patients from the URTC group and looked into the outcomes of what might be the group who needs to be absolutely transplanted and who will not. And in this, and this is again just to suggest in the disease-free survival that the intermediate risk group did not do on your right hand side, did not have so much of a benefit depending if you did a transplant. But when you did the meta-analysis, it became even more clear, and this was published in 2007, mind you, wherein there was certainly a benefit for the intermediate risk group and the and the poor risk group, but not for the favorable risk group as is suggested in this forest plot over here. So the conclusion was even more strong when the meta-analysis was published in JAMA, which is from Korath et al., which looked at almost 6,000 odd patients, wherein the relapse-free analysis was done. And again, very much similar to the forest plot that was published by the Hovansak group, there was no real benefit for those patients with the favorable risk group. So when you're talking about patients who need to be undergoing transplant on a broad basis, definitely if there is a donor available for an intermediate or for a poor risk group, certainly they should be explored. And of course, again, mind you, these were in patients below the age of 60. And this was again the overall survival benefit pretty much the same. So compared with non-allogenic stem cell transplant, allogenic stem cell was significant relapse-free survival and overall survival benefit for the intermediate and the poor risk group. Now, let us play the devil's advocate again in another way. So do you need to actually transplant all those patients who have gone into CR do an allogenic transplant for all these patients? So this part was explored by the MRC group, and this was a paper by Alan Burnett who published this paper in 2010. Basically, the idea was to quantify the prospect of salvage treatment for patients who did not undergo an allotransplant in first CR, and to assess the contribution of an allotransplant in second CR as and when they relapsed, and also to explore the information for a decision to offer transplant in CR1 based on the large data that was looked into. Again, this was a large study. They looked at 3 studies, MRC 10, MRC 15 study. And what we looked at over here is that the relapse-free survival was significantly better for the favorable side. Nothing to be surprised about over there. And also for those patients on whom the cytogenetic profiling was not done, they also were falling somewhere into the category of the intermediate risk group. And again, when you looked at the percentage alive at the end of 5 years, when we did not do a CR, there was about close to around 50% for the, little more than 50% for the favorable risk group, and less by around 15% for the intermediate risk group. And as is true for the poor risk group, they had a very poor 5-year overall survival. So the result of almost close to 9,000 patients from an AML 10, 12 and the 15 trial was that they had looked into about a little more than a fourth of the patients had relapsed after standard therapy for these patients. They did not go and undergo a transplant. But what was inferred from the study was that for those patients who actually relapsed and underwent a transplant in CR2, they actually were salvaged better than a patient who underwent a transplant in CR1, and the salvage rates were only around 7% as against about close to 20% for patients who were undergoing an allotransplant when they relapsed into. So the conclusion of the study was that it may be better to do a CR2, not it may be better to do a CR2, but you may decrease the number of transplants and the morbidity associated with transplants by waiting for doing a transplant in CR2. So successful salvage treatments who do not undergo transplantation in CR1 can be achieved in about 19%. This is improved by a transplant, except, of course, in the favorable risk group where you don't need to do a second transplant also if the time to relapse is long enough. So are there special situations where a perceived favorable risk group are better off with a transplant? We do know that there is always this uncertain significance of c-KIT mutations with the co-binding factor leukemias. This was a paper which was published in 2006, which looked at the impact of c-KIT mutations with the co-binding factor leukemias. You will find that the c-KIT mutations are a little more common with the inversion 16 leukemias than with the A21 translocation leukemia.